Hello everyone, this is Dr. Rajesh Mishra and you are watching Health Super Specialist. So as I promised in my last video in the discussion about community acquired pneumonia, that in the next video, subsequent videos will coming up with the diagnosis and the management of community acquired pneumonia. We discussed a few scores in the last video, but in order to shorten up the duration, I had to wind it a bit more quickly. So coming to the diagnosis of community acquired pneumonia, there are various scores available which are given by different societies, different big organizations which help in the diagnosis of community acquired pneumonia. The first score that is given is the PORT score, or also known as the Pneumonia Severity Index, in which it's a very big list of 20 points. And based on the score, the patients are divided into class. Class 1 to 2, they are managed at home. Class 2 to 3 patients are managed in hospital setting, and 3 and 4 are managed in ICU setting. So this is something called the Pneumonia Severity Index, a 20-point score used to diagnose a community acquired pneumonia and where to manage it, and regarding the prognosis of mortality. Then there is curve 65. As we discussed in our last video, confusion, the mini mental score of less than 8, uremia, blood urea nitrogen of more than 19 milligrams per dl, the respiratory rate of more than 25 per minute, the blood pressures of less than 90/60, and age of more than 65. So this is the curve 65, and a curve 65 score of 1 to 2 requires an OPD treatment. Around 3 will require something of inpatients, and 3 to 4 will require ICU management. So as well as it predicts the mortality. So in order to make it simpler, curve 65, what they have done is they have made CRB 65. They have removed the urea, because initially when the patient is with you, you may not know the urea of the patient. So confusion, respiratory rate, blood pressures, and age of more than 65. To enhance it, suppose you have got an endowed surrounding in which you want to diagnose a community acquired pneumonia, it's called expanded curve 65, in which we include LDH, we include platelets. So if we include LDH and platelets, it's become the expanded curve 65. Okay. A part of curve 65, we have the American Thoracic Society criteria for community acquired pneumonia prognosis and place of management, which is called the ATS, American Thoracic Society, and it includes 2 major criteria and some 9 minor criteria. The 2 major criteria are like septic shock and requirement of mechanical ventilation. The minor criteria will include like a respiratory rate of more than 30 per minute, a PF ratio of less than 25, multilobar infiltrates, and then confusion, new onset confusion. There is hypotension, there is hypothermia, there is thrombocytopenia, there is other 2 things will be there. So this major and minor. So if 1 major and 3 minor are present, the patient deserves or even 2 minor are present, the patient deserves to be managed in ICU setting. Okay. So this is the ATS score. Then we have the Australian score, like it's called the SMART COP. What is the SMART COP? S will stand for systolic blood pressure of less than 90 millimeter of mercury, M for multilobar opacities, and A for age, and R for respiratory rate, T for tachycardia, C for confusion, O for oxygenation, and P for pH. So this is the Australian score devised for the diagnosis of community acquired pneumonia, which is called the SMART COP. Fine. So we have seen all the scoring systems. Now how do we diagnose? Whenever we see any patients, I think the first investigation that we used to need is basically the basic lab parameters of CBC KFT, which gives idea about the leukocytosis, about the blood urea, which will incorporate in all these scores and get to know the place where to manage the patient of community-acquired pneumonia. Okay, chest X-ray, of course, is very, very important to see the multilobar infiltrates, which we have been discussing so many times in the course, and sputum culture sensitivity. CT is a gold standard, but not meant for patients who are managing home or ward. Then we have other modalities which can be utilized in patients in ICU, like urinary antigen test for pneumococcal and Legionella. And because if we come to the organisms, I think I missed out initially, the most common organisms involved in the causation of community-acquired pneumonia are like, if it is viral, it is rhinovirus, it may be influenza virus, it may be para-influenza virus, it may be human metapneumovirus. If it is bacterial, it may be streptococcus pneumonia, it may be a drug-resistant streptococcus pneumonia, it may be a Haemophilus influenzae, it may be a atypical mycoplasma pneumonia, Legionella pneumophilia, or it may be some uncommon organisms like Mycobacterium tuberculosis, atypical mycobacteria. So these are the organisms which commonly cause the community-acquired pneumonias. Fine. So now it's like community-acquired pneumonia. The diagnosis part stands for urinary antigen for Legionella, pneumococcal antigen, X-ray, blood test, basic blood test, CT. Coming to the more invasive tests, which are specifically meant for sicker patients, that is a patient in ICU, you can either go for a bronchoalveolar lavage, you can go for something like mini-BAL, you can go for a protective specimen brushing, PSB. Now for each of these maneuvers, you have different counts which are significant. Suppose for protective specimen brushing, even if it is like more than 10 to the power 3, it is significant and you have to treat the patient aggressively. If it is in BAL, it is like 10 to the power 4 organisms. And if it is in the mini BAL, then probably 10 to the power 6 organisms, which is counted as significant. So different counts for different maneuvers that you perform in an intensive care setting for more sicker variety of patients. Okay. Now coming to the treatment part. So I think I am exceeding my specified time limit. So for the treatment part, hope to see you in the next video in the treatment of community-acquired pneumonia. Till then, thank you. Thank you very much.